All right, welcome back for another video. I thought it would be interesting today to actually take you through a case that I actually haven't completely worked out yet. I think Kodachrome sessions are a lot of fun, and it's kind of fun to see where something begins and from a case perspective, what's happening in our mind, how we work through it, and how it ends, and what the conclusion is. But I also think it might be interesting to to kind of see how a dermatologist thinks through some challenging cases, especially one that's ongoing and not yet solved, so to speak. I think a lot of the lessons that we can learn and take away from challenging cases are the paths to get to the correct answer rather than the actual correct answer, and the way to think about something rather than what the actual outcome is. So what I'm doing today is I'm actually presenting a case in the electronic medical record, cropped obviously for privacy, of a case that I don't have yet figured out. And so this was a patient who I've been working on. And so I have some images that I'm going to flip through. I want you to kind of just generate a differential diagnosis and see what you think. And so I'm just going to flip through some pictures here. So here's the left upper extremity. Here's the right upper extremity. And feel free to pause the video and try to generate a differential diagnosis based on some of the previous videos that I went through in terms of putting it into an appropriate bucket. I'm not going to go through that again just for time's sake. Here's a closer view of the left upper extremity. Here you see the biopsy sign where we circled some areas where we biopsied. And here is a closer view of the right upper extremity. Okay, when you see a case like this where you have these necrotic plaques on the upper extremity or really anywhere, there's a few things that should come to mind. I want you to take a second and try to, again, think about what those things could be. Basically what you're seeing here is epidermal disruption. So you see that there's necrosis here, you see that there's scale buildup, and that tells you that the skin is dying. Here's another view, so full thickness ulcerations, eroded plaques, and nodules. The skin is dying. And so because the skin is dying, you know that there's something that is interrupting the blood vessels. And so when you see this, and when I first met this patient, seeing these necrotic plaques, erosions, full thickness ulcerations with this kind of erupted layered crust, there's really a few things that come to mind. So the first thing would be an infection. Some bad infections can absolutely do this. So it's not going to be usually a staph infection or your run-of-the-mill infection, although it can be staph, but sometimes more exotic infections like fungi or atypical mycobacteria, leishmaniasis, leprosy, really weird infections that interrupt the vasculature and cause cutaneous necrosis. The other thing you want to think about is inflammatory conditions. So vasculitis can do this. Now, this isn't small vessel vasculitis, kind of the palpable purpura on the lower extremities. This is more going to be medium vessel vasculitis. So you think about ANCA-associated vasculitis, IgA vasculitis, lupus vasculitis, rheumatoid vasculitis, probably some other ones, cryoglobulinemic vasculitis, and some other ones I'm not thinking about are going to be the main ones that you're going to think about in the differential here. And the last thing is going to be cancer. When you have an overwhelming cancerous process, the neoplastic cells interrupt the blood vessel and you get a necrotic process like this. Again, these aren't going to be mets, but this is going to be a primary cutaneous process. It's usually some type of lymphoproliferative disease. So T-cell lymphoma like mycosis fungoides, primary aggressive epidermotrophic cytotoxic CD8 T-cell lymphoma can look like this as well. Many different processes can present similarly. And so looking at this, you can't tell what this is, but you can tell kind of where it is, if that makes sense. You can tell that it's a dermal inflammatory necrotic process, inflammatory, infectious, or neoplastic. And that's really where I'm at. So I did a couple biopsies, and the biopsy showed pseudoepitheliomatous hyperplasia with neutrophils, or PEH with pus, which is common differential that we're kind of confronted with in dermatology. And when you see that, that means that the epidermis is thickened, pseudoepitheliomatous-wise, which means almost looking like squamous cell carcinoma, and there's neutrophils underneath it. And typically that puts you in a camp of infection, like we talked about, weird infections. Inflammatory diseases, pemphigus vegetans can look like it as well. And then weirdly enough, something that I hadn't considered in my pre-biopsy diagnosis, which is halogenodermas. So iododerma or bromoderma, which is basically someone who has renal failure exposed to one of these iodinated or brominated compounds, and they get a neutrophilic reaction in response to that. And so that's where I'm at. As of today, I'm between one of those three entities. The biopsy gave me PAH with pus. I don't know what this is. I have some blood work pending that I'll follow up in a following video, But right now, because the differential histologically and clinically is between infection, pemphigus vesicans, and iododerma, I am sending this off for universal PCR, also checking desmogleins for pemphigus, and then iodine and bromine for those entities as well as some other lab tests that I'll discuss in a future video. So not sure what this is. Very weird entity. This person is suffering from this. Going to try to figure it out and keep you updated as we move through this diagnosis. So difficult case. I hope you like this video. If you enjoyed this video, please like and subscribe and share with other medical students and derm residents. Thank you.